this talk is really going to be along the theme of National Clinical Audit, so what? What's it done for me? Because that's one of the themes that does come out. So HQIP is an organisation that's brought together. It's a partnership, and the partnership bit is important because it's a partnership it's like a charity with a board, the Medical Academy, Royal College of Nursing, the big patient concern group. So we have those three groups leading us and gives us a lot of power actually in terms of going up against NHS England and the like, bearing in mind that we are independent, although we all live in the real world and we get vast majority of our money from NHS England to run the audits. But you can see what we actually get up to here. This is the National Audit Programme. Patient outcome is POP. But we do these other themes as well. This is what most people would know as the Confidential Inquiry Programme, which came in quite a number of years ago. The Joint Registry sits in under there as well. So there's quite a vast number of what should be really important quality improvement tools, which some aren't, and which we are doing a lot of work on to make sure that they are. It covers England and Wales, and sporadically Scotland, Northern Ireland, the Channel Islands, and indeed we've got, I think, one thing going on in Southern Ireland as well. But the important bit that I'm just going to talk to you today is about the National Clinical Audit Programme. A burgeoning programme. Actually, quite a few of the audits have been going quite a few years, and indeed for various kind of strange reasons, mostly to do with finance, the vast majority of the audits are being re-tendered this year and next, which is actually very opportune because it gives us, and us I mean all of us, an opportunity to have our say in what's actually going on, what's being measured. Like none of us are blind to this. Many of us understand that these started off as projects, really, really well-intentioned projects from organisations like this and societies, but have tended to be held on to quite tightly by clinicians. And there has been the paradigm whereby we had the audit, the results came into the lead clinicians, they all got together in a little room, looked through them, thought that's very interesting, put them in a drawer, and that was the end of it. Now that obviously is not tenable, and most of them have moved on, but there's a lot more we have to be doing. I'm going to talk actually at the end about some of the other themes to do with, that Derek's already mentioned, about leadership and, you know, change, that whole thing about change, which you're obviously all right in the middle of. And the reason I'm showing this is not to teach you the definition of audit, but the first line is improvement. And it is really, really important that we who run these audits and commission them make everybody understand that these are not exercises to collect numbers. We've done that bit. This era is making improvement, and it's only by us doing that will we justify the budget and actually increase the budget, because we're all in very straitened times at the minute. And implementing change. These like, I'm talking to the converted here, and we have to get that message on out to the field, to the front line, that these are really important tools. They've got the best of measurements. The methodology keeps getting better and better, and indeed we lead the world on this bit about methodology, but we must actually get action so that things get better because we're doing this. I'm just putting this up because I think this summarizes the whole measurement thing up pretty well. We measure and measure and measure, but are we actually making things any better? And we have to keep doing that, because when we go up asking for money, virtually the first question is, well, what changed when you did it last year or the year before or whatever? And actually, when I go and ask an audit, they find that a difficult question to answer. Like that should be innate. Yes, we did this and therefore that got better, or that wasn't good enough, or whatever. Now this is the paradigm, and this again, we've put improvement right at the top of this. It's, you know, we just can't have anything else going on other than these are there. They do quality assurance, that's really important. We can't lose that. So the services use these to assure their services, and indeed this is what we want them to be doing. Some of them actually don't know, and we'll come back to that. But obviously all these other things, the quality of care, the next talk is to do with variation. This is the way you pick up variation. You pick up variation here, and that gives a doctor, a nurse, a manager, a board, a chief exec. Well, what are we going to do about this variation? Right, so I happened to end up with a meeting last week, Don Berwick, who's an evangelist on this. I thought this is a really good slide. I kind of stole it, so to speak, but anyway, because although this actually is into a PDA cycle and essentially for our local audit theme, nevertheless, it applies across the board in terms of improvement. What are we trying to accomplish? It's unbelievable how we go in, a college comes along, and they want an audit, but actually when you ask that, well, what's it at? What are you after here? Actually, well, we have to go and think about that. You know, that's the first line, isn't it? How will we, I'm going to talk a bit about change and improvement. How will we know that this change and improvement, like that's a really interesting theme, change and improvement. And okay, so what are we going to do about it? And that's the one that really does get left out. And then Don obviously moves on into the PDA cycle, his model. But this, and there's loads and loads outside I can see on the posters with local audit, which is incredibly good, obviously. But this is the kind of cycle, I don't like cycles that little bit at the bottom. It's the whole theme of what are we setting out to do here to make things better for patients. So how do we drive improvement through national audits? So these are the fundamentals really to do with our national audit. And it's really important that first question is the first question. Are we asking the right question? Now, this is really important for us in the retendering exercises because a lot of the audits, like for instance, the audit into cardiac pacemakers, which has morphed on into ICDs and the like, it has been going, I think the longest, I think it started in the 70s as a registry of pacemakers. I actually met with them recently and we were having discussions. And it's quite clear it's just moseyed on and on and on. And they don't know what the questions are. For instance, there's things like no GMC numbers in that. So getting, what is the question? And this is money each year. What is the question? And it's not going to be the same question last year. And certainly not going to be the same question for 5 years ago. So it's keeping these things refreshed is really important. And then the audiences. It's not the interested clinicians. They are incredibly important. But everybody in this room here will know that it's not the doctor bit, it's the whole bit. It's managers of healthcare organisations, the medical director, the chief exec, the chief nurse, the board of the trust. We obviously, the governance systems in our institutions has massively improved because of the various, scandals that have come along and shown deficiencies in governance. Governance now, I think, is very good. But they all need to know what's going on. And I've got one or two slides to show you how we've been working on that. Patients and the public. So it's no point in sending out a document with 100 pages to a bunch of patients. Like, I can't follow many of these things. How can anybody else follow these? So it is getting something out that says, we did this, we spent this money, and we've got this out of it, and we're going to do this about it. And that's what patients will understand. And by patients, I mean the public, I mean journalists, I mean politicians, probably the people really that we need to get at, probably the people who least understand what we're doing here. They need to be helped through this because we're actually spending taxpayers' money. Commissioners, again, that was like PCTs rose up and we're starting to get a handle on this and then dropped again. CCGs now have got a handle on this again. So we've got CCGs and specialist commissioners in this. So we need to work with them so that they know that this resource is out there so that when there's reconfiguration going on everywhere, if you're starting to reconfigure, are you using the best information to make decisions on? And regulators, and we have been doing work with CQC on this, and I'll talk about this. Timely reports. I'm going to talk a little bit more about reports and the like, but basically, this has to be the way we're going to go. Like, lots and lots of the audits have moved into the web-based real-time information going in. So real-time information has to come out. Now, some of the audits are not designed for this and probably won't ever do that, but many, many can, particularly all the interventional procedure ones. And indeed, if you actually think it through, if you're doing interventional procedures and you're putting information in and you're sending it out, the audit provider really is, what they're doing is cleaning it so that there's not a year like 2099 or something. you should know as the data leaves, so it doesn't come back as a surprise to you. That's really important in this bit to do with the sun getting a hold of somebody's an outlier. You should, in your institution, know these results. They should be live in your institution, so that the person deviates off or whatever, you're onto it, so that actually harm doesn't happen. You avert this, and so we don't get headlines and people being pilloried in the sun because the result has come in 18 months after it's actually all happened. Now, this is one of the projects trying to address the question. Sorry, I lost my way here. Trying to answer the question: are we asking the right questions? So, this is a project we set up with CQC, but it's actually exploding into a much more important project. So, CQC came to us and said, right, we go and inspect a hospital, we get all this information from Pricewaterhouse, every clinician, nobody believes it. Can you give us the right information? Now, everything I'm going to show you here is publicly available. But what that means is there's a document comes out that's got 100 pages. It's on the web in a PDF format, so it's not kind of usable very easily. And if you're a medical director in an institution and one of these comes in, it would take you, and I have done this, and I've done it as medical director of H Group, it takes you the weekend to go through it and say, what's the message here? So CQC obviously couldn't hack that, rightly so. So we started working out. So what we set to with one of our fellows was, we sent the fellow round each one of the audit providers running one of these audits. And the question to the audit providers, okay, you're measuring 100 fields. What are the 5, 6, 7 key things to look at? And you can imagine there's a lot of knocking things about, well, it's all very important. It's all very important. Right, give us 5 measures. And actually all bar one, and I'm sure you can guess the one that wouldn't go along with this, all bar one acquiesced to this. So we ran this pilot, and this is in Manchester because that's where I come from, and that's where I can spread the news around and manage to take this stuff coming back at me pretty easily. So we've got, I think it's 9 hospitals sitting around Greater Manchester. We said to CQC, right, we're going to go do a pilot with 6 of the audits, and there's a rolling program on this. And we'll do it for all of the 9 hospitals in Greater Manchester. And just as an aside, what was really, really good about this, I'm not going to show that slide, is one of the hospitals is the Pennine Trust. One of the trusts is the Pennine Trust, which is 3 or 4 hospitals. So we were able to get results, not just for the trust, but by the hospital as well. This shows hip fracture. I'll just move to the next slide. So hip fracture said, right, these are the 6 key measures. And you can see that it all makes sense. The second one obviously being the one that the real key thing with a nice guidance surgery within 36 hours. But moving back, you can see how each one of these measures then was benchmarked. Each one of those diagrams on the right is there's a complicated, very complicated set of mathematics going on behind that. But you can see, so now we're not seeing South Manchester Hospital versus hip fracture versus the UK. We're seeing it down to the domains that have been picked out. So if you're a medical director and see that, think, well, actually, we're doing really well here, but actually there we are in include overall length of stay. Wow, that's good. So phone call, what are we going to do about that? That's instant. You can imagine when I took these round, your equivalent, the AHSN, who are already doing a lot of information work, they're kind of biting my hand off for these things. Again, just to show it's not all to do with things. This is intensive care unit. I haven't spelled this out. But so this is, and these are how many measures? About 5 measures for intensive care. You all know how expensive intensive care is. So there are the intensive care doctors, clinical directors, medical directors looking at their intensive care outcomes by 5 measures. And the reason I mentioned Pennine is because they've got 2 particular intensive care units, one doing very well, one not so good, as culture would have it. So for the first time, the medical director was able to look and say, actually, now I know why these ones are doing well and those aren't. So this is asking the right questions and getting the audits to focus in on what's important. So how do we drive this? Continuing on. Okay, so we've got the report. So the report now needs to focus on the important bits, not the huge pages and pages of diagrams. Here's the key bit. These are the 3 messages we keep banging on, saying, you've done the audit, give us 3 things that you've found that are important, and 3 things in the recommendations that everybody needs to go and do. And these reports, you know, if you actually get down to what's going on, the reports are written by analysts, and then the doctors pop in at the end and add in their bit. That's mostly all of that can go into the annex. We need the early bit, which is the key messages, and that's the message we're putting across. And we brought this document out. I hope you've seen it, Reporting for Impact, and that's got all of this stuff in it. And we're becoming like Don Berwick now, you know, small version, evangelists into this. We have to get, because we need more of this good measurement going on. And that's the way we do it, by showing impact. These are a few examples. Emergency Laparotomy Audit, I'm sure some of you are involved in this. We're not going to read through this clearly. This is how you do a report for impact. 1 page gives you top left-hand side recommendations. So cut to the chase. What are we going to do differently? And then everybody loves the kind of little caveat below that. So that's what we need to be doing. I need to get on here, but right. So stroke. I'm just showing this because this shows you doing well and us not so well in Manchester, and the UK not doing so well. So can you imagine all those fans of Manchester United, Manchester City, looking at this, thinking about those guys down there? They're doing a lot better. That's what we need. We need to hook that stuff in so that we get those kind of rivalries in a positive way, not the very destructive way we've had in the past. Quality improvement, this to the lung cancer. So these are different ways of reporting to make things better. And I'm showing these next few slides because this is us coming in on standards. Some of the audits have deviated off standards. You'll all understand that. You've got nice standards. You're working to those. So aren't we auditing you to those? So we need a lot more of that. And so this is a graphic showing how this is kind of hitting in on the standards. Now, the next 2 slides are actually relatively, very recent audits. One to do with acute inflammatory arthritis, so that the NICE quality standard came out relatively recent. The other one I'm going to show in a second is to do with acute psychotic illness. And you can see how this is the way it's going. Quality standard, they're the standards. This is the audit. What does the audit show? It shows catastrophic care. So this is the recommendation that we should be all doing. Acute inflammatory arthritis, straight to appropriate therapy. And here's what we're doing. So that's about 3 days, and that's 20 days. So I'll show the next one, and I'll come back to that. This is the acute psychotic one. I think the 3rd standard for acute, first presentation acute psychosis is prescription of clozapine. 2/3 of patients not getting it. Now, so wow, that's a finding. So, okay, we're going to just think about that and drink coffee. No, both the Rheumatology Society and Royal College of Psychiatrists have gone off and written action plans and tools, not just we're going to think what you should do. Here's what you need to do to make this better. So that's the way we need to be moving. And then a few other things. Reporting for impact, right? So not big diagrams, graphs. This sums up the whole of this. Takes a few minutes just to work through that, but it takes a lot less than a weekend to work through it, which is the way it used to be. So immediately you get the message. This is what we need to be. This is how it's come out. I'm just showing this to spike the next talk, really. I learned a lot. I learned a lot from these. These are wonderful. These are wonderful charts, and I think only you can do the maths. But it's getting that out. Doctors love these. Nurses, doctors, patients all understand this happens to be with hip fracture and achievement of the 6 functions. And do you know what? What happens here is money comes in. Yeah, money comes in, and that's where it gets a lot better. So there's ways of bringing this all together. And then the last thing to do with doing this is workshops. Teaching people, showing them, teaching them. That really makes the impact. And this was all to do with inflammatory bowel disease. And indeed, it was so successful, we don't need to do this audit again because the whole thing's having a big impact with the biologic agents. Right, last few slides, just to, this is the whole change management things. Improvement and change. So I think we all understand improvement needs change, but does change always give improvement? No, it doesn't. So that's why it needs to be led and managed. And it's hard. We're human beings. We've got a culture. We do this. I've always done it this way. So to move across that we're going to do it that way needs help and management. And that's where leadership, Derek's mentioned, leadership comes in here. You need leaders and champions who take these on, and early responders and all that stuff. You always know this stuff. Change involves a loss. Why would I? But I've got one or two other slides that I think are really interesting. There's a small amount, there's not a lot of research into this. Why is it hard to make change and improve things? And it's all of it's to do with us being human beings. Limited knowledge, that's absolutely true. So that's where these events come in. Teaching people. We as doctors and nurses are not trained to do this. We're trained to diagnose and treat illness. We're not trained in quality improvement. It needs a special bit of help on this. Not massive, but some differing definitions about quality. You know, we can all argue, well, that doesn't really matter. You know, you've all heard these arguments. Well, we're doing fine. That place down the road, they're the problem. It's not us until you measure it, and we're all sitting about 75%, and we all need to improve. That's not my job. My job's to come in and look after sick people. You know, it's somebody else's job to do this. It's all of our job. And the last one is the important one. And I've heard this so many times. I'm a surgeon. I work with anaesthetists. That's the message that they always give out. So you want me to do this, to write a guideline, to do an audit, to implement change. So that means I'll go away there and I won't be treating this patient there, so that the whole service will be worse. That's the argument, and you have to address that, because that's true. But the increment of getting everybody into a culture set of improving things gains. And lessons learned, and just leave this to the last slide, it's so important that clinicians lead this, because once you get to this other bit, done to them, you all know this. Well, what do they know? What do they want me to do? Yeah, it has to be led by and done by us. Need leaders and champions. Articulating the vision. This is Don Berwick kind of message, and we're not going to have to sing and hold hands and all that stuff, but actually articulating the vision, and not, if it's not working, change it. Like we don't always get it right. And another plug for the control charts, because they are wonderful. And then rewards do matter in all of this. So thanks very much for that.